injections. These are often steroid injections. They may last weeks to months. And then advanced procedures, your ablations, your nerve, implanted devices such as spinal cord stimulators, that can last months to years. We have patients who've had spinal cord stimulators for 10 years and they just replace the battery, similar to when somebody has a pacemaker and they just replace the pacemaker battery and they preserve that function. So caution in the elderly, be mindful of blood thinning medications. So some elderly patients are going to be on medications that thin their blood, things like Plavix or clopidogrel or Xarelto, and these or Coumadin. And these medications can put them at increased risk for bleeding with certain procedures, especially around the spine. So we need to be aware of all of the medications you're taking, not just the ones you're taking for pain, so that we can tell you how to safely take or not take certain medications for the procedures we're doing. The other things we have to be mindful of is if you have other electronic devices in your body and we're using electricity somewhere else in your body, we want to make sure that electricity doesn't interfere, like with a pacemaker. And then, of course, anatomic changes. Sometimes, as you heard, the spine can degenerate and you can develop stenosis or narrowing of the spine, and to the point where certain procedures may not be as safe at that particular level as others. So as your physician, it's our responsibility to understand your anatomy, what's going on with your spine, or what's going on with different parts of your body, and make sure whatever procedures we recommend are safe for you. Then we've got physical therapy. So the types of physical therapy vary, and there are plenty of different options: manual exercises, aquatic, water therapy, or other. But then I want you to be thoughtful when your physician talks to you about physical therapy. Make sure you understand what the goals are. Are the goals to improve your pain? Are the goals to improve your balance? Is it that you've been falling down because you can't keep your balance right? Is it that you've been weak on one leg and that leg is not holding you up and it gives out? So there are different goals for physical therapy, and if you understand what those goals are, you're going to be better able to comply with therapy. In the elderly in particular, we want to make sure that we are treating them and, again, addressing what's limiting their function the most. In some of my patients who are older, I'm not trying to get them to physical therapy to do back bends and back flips and all this other stuff. I just want them to be able to get up out of a chair and walk down the hall without hurting themselves. So I will tell the physical therapist, I want you to get this patient up and down out of a chair and walk steadily with a walker, teach them how to use it safely, and then when that's done, you come back to me and we'll work on the next step. Maybe the next step is to help you walk upstairs. I'm not going to have you walk upstairs if you can't get out of the chair yet, okay? So this is all about being specific, strategic, and safe. Then finally, your psychosocial treatment. You've got different types of psychosocial treatment: counseling, meditation, biofeedback, and other. These are all different types of psychosocial. We heard from our psychologist before the break. But there are other treatments that can be used too, such as certain medications. Considerations for the elderly, though, involve, very importantly, cultural resistance to psychosocial treatment. So we have to remember those 4 E's of patient education: engage with them, empathize, and explain, and then empower them to choose. Those are the 4 things that are going to help us interact and engage. You may not convince somebody who might need psychosocial treatment the first time that they need it, but if you maintain those 4 E's as you try to educate them, that is going to help them move forward with treatment. And so I'm going to end, hopefully this will play, because why does it really matter? So here, you remember we started with church mothers? Those are my church mothers doing their praise dance. Check out those feet. Thank you very much.
My presentation isn't quite so entertaining. I got no church mothers, but I do have one grandmother in the talk, so we'll go with that. I want to talk to you about this last session is cancer pain management and targeted pain treatment, and what that actually means. And cancer pain, as you can imagine, can be rather painful. It turns out that more than 50% of all people with cancer have severe pain, and that even includes the people who are treated for their pain. They're called survivors. 33% or more of them still have pain even after their cancer is treated. So cancer can be a very painful, debilitating condition. And we're looking at all those with cancer pain. Almost all of it's the result of the cancer or the cancer treatment. I think a lot of times that doesn't come across when you're talking to your oncologist about the treatment of your pain. You have radiation treatment, you've got chemotherapy treatments, you have surgical treatments, all of which can damage the nerves and create a chronic pain condition. Yes, you might be lucky enough to have your cancer treated and survive that, but we want to really talk about the quality of your life and to treat that pain even after you survived your cancer. When we look here at the cancer survivors, we can see that we're about in between 2020 and 2025 here. Large proportion of folks that are growing that are cancer survivors, and look at the age group, basically over 65 or over 50. So as we get older and we survive cancer more, we have more and more people in this age group that have severe chronic pain. What's the issue about folks in that age group? Is that they don't tolerate meds quite as well as the younger folks, right? And it's a real problem. Here we have 80 to 90% having decent pain control with a variety of medications, including opioids and whatnot. But there's still this 20% that are recalcitrant, severe, neuropathic, nociceptive, normal pain, abnormal pain after their cancer treatment. The woman we heard from earlier talking about her multiple back surgeries, right? She had the spinal cord stimulator, which is a pretty advanced treatment, and it does help many, many patients. But did you hear Dr. Gilmore mention that it doesn't help everybody, all right? He was mentioning something like 75 to 80% of the patients get help with that for their specific neuropathic pain. But what if they have just normal pain? Just, you know, the arthritis in their spine is so bad, multiple spine surgeries like our participant talked about earlier, and they're still having pain. She was told that she was at the end of her treatment options and just go home and take some Tylenol, and that was going to be the end of it. And unfortunately, that's not the end. All right, what's the issue with a lot of these medications? We already talked about the fact that a large proportion of patients are elderly. When they get severe pain problems, we're growing to be older. But when we're growing to be older, doesn't mean that our bones are sustained, doesn't mean that we can necessarily function quite as well, and we have more and more pain problems as we get older. And taking medications, especially among the elderly, is more and more problematic. There is an experiment that I ask my patients to do, and I have a feeling I can do it here. But I did this with Dr. Johnson, his brother, Dr. Johnson. I did this experiment about 15 years ago. This experiment was, our grandmother was alive then. She died at 104, but back then she was alive. And we went to a wedding. One of Dr. Johnson's sons got married, and my grandmother, their grandmother was born in 1913. And we're at the wedding, and the couple that was getting married and the groomsmen and all those folks, they had a bottle of champagne, and they drank a little bit of champagne, and they had another bottle, and they all had champagne, right? My grandmother was at my table. I poured her a 1/4 inch of champagne. She went to sleep, all right? That's the problem. You can't tolerate it. So when we look at drug addiction and tolerance, that's why we're, as pain doctors, we're so doggone concerned about exposing the young folks to opioids, because they develop a tolerance very quickly, and that leads into the addiction and all the side effects. We did an experiment at UCSF. We looked at the rate of tolerance in those people over 65 versus people between 20 and 50. At between 20 and 50, they skyrocket in their dosing, and they get to really high doses very quickly. Folks over 65, they can go between 65, 75, and 85 and only increase a small amount, all right? And we did that experiment in both humans and in animals, found the same thing. The problem is the elderly just can't tolerate a lot of the meds because of the side effects and the complications from those medications, and they can't get the kind of pain relief they really need. And who has the most severe pain? People with multiple surgeries, with the cancers, with the arthritis in the knees and the ankles and the shoulders. Who are these folks? Our elderly population, right? So you have people with the most severe pain, having the most difficulty with the medications we have. What can we do? What we can do is, we've already talked about the fact that we can target different parts of the nervous system. We can look at the periphery, we can look at wherever the nerve's coming from, and anytime we can engage with blocking that pain signal from getting from wherever it happens to be, all the way up the nervous system, through the spinal cord, and all the way to the brain, we have multiple spots where we can try and impact upon that. All right? We talked about spinal cord stimulation being one of those options, but sometimes even that's not enough. Sometimes we do need those opioid medications in very, very specific targeted locations. We talked about nerve blocks already, so I won't get into that in too much detail. We're going to call it nerve zapping now. And this is a technique where we place this needle here over the nerves that go to the pancreas for people with pancreatic cancer, or even if you don't have pancreatic cancer, just chronic pancreatitis. We can zap that and do that once a year, and you get benefit with that. That's one option. We already talked about spinal cord stimulation, but I thought I'd show you some pictures. Here are the little wires that go in the spine. Here's the little batteries. Here's what it looks like on X-ray. That connects to that, and you have a remote control for that. So that's the targeted electrical stimulation. But like Dr. Vanderpool said, we have targeted therapies of various sorts. One of the things that we need to do is target the actual nerves transmitting that pain signal to your brain, even if it isn't just because of a damaged nerve. It's just normal pathways, and we need to use medication sometimes. We just said that you can't take the oral medication because of all the side effects. What we can do is take the medication out of the body. All the red here is all the places the medications go when you take it by mouth, by IV, by sublingual, by any way means, by transdermal patches, still ends up in the bloodstream going to your entire body. What's that give you? Constipation, sedation, nausea, vomiting, all the things that you don't want, right? What we can do is we can take a fraction of that, the smallest minuscule amount, and put it directly into the spine itself and put it right over where those nerves are transmitting the pain and provide you pain relief without any of those side effects. That's called, we call it intrathecal therapy or pain therapy, where we have a little tiny catheter. This catheter is about a quarter of the size of the IV that you would see in the hospital. Very, very small little tiny tube that delivers a very small amount of medication directly to that part of your spinal cord. All right? And about 1/100th. So just think about how many pills you'd have to take 300 milligrams of morphine. It'd be a bucket full of pills. I can translate that into 1 milligram, directed right at that part of the spine. Doesn't go to the brain, doesn't go to the GI system, doesn't go to the liver, doesn't go to all the places that you're having problems with. This is another technique that we can do. We use an implantable pump. That pump goes just underneath the skin, right in the abdominal area, and the catheter goes around to the back and into the spinal fluid, and your doctor will target the area of the spinal cord where your pump is, or where your pain is being transmitted. All of that without any of the side effects that we just talked about. Here's a case of an NFL football player named Patrick who was suffering, ended up with a diagnosis of multiple sclerosis, suffering from pain, spasticity, wheelchair bound, couldn't move, couldn't do things, and had severe spasticity and pain. He got one of these devices and was able to manage without significant pain and move around much better and less spasticity. This is the grandmother. That woman who talked about earlier who had a spinal cord stimulator, didn't work for her anymore, and had 3 back surgeries. She's had 3 cervical spine surgeries, 3 lumbar spine surgeries, and if she took one opiate, she actually has nausea and throws up. All right? How are we going to get the pain control she needs and get her around? Dr. Vanderpool just said that we have to get her up and about and moving around. All right? This is my mother. And she had to have that pump in place in order to get up and get around. But not only that, she lives in California in the same time as me. And she needed to come out and see her mother, Dr. Johnson's grandmother as well, which is 3,000 miles away with all that pain. All right? She gets in the airplane. She has pain with sitting for too long a period of time. All she needs to do is reach back and get the little device here, push that button, she gets a little extra pain relief. All right? Doesn't need to have any nausea, no constipation, no vomiting, and gets pain relief that way. So that's what we're looking for. We say targeted drug delivery, targeted therapies. This is where we're headed. This is what we're doing. And if your doctor's not doing it, you can ask for a referral to someone that does do it. Never give up. That's the key. And Dr. Salino had a death in the family just 2 days ago, so he's at a funeral today, so he won't be able to make it. So Dr. Turner is going to be talking to us about more advocacy issues, and then we'll open it up for questions.
Good afternoon, everybody. So I think your sugar spike is starting to come down right now. So if you go to sleep, I won't feel bad, okay? Lunch is over. So yes, I'm Shafanya Turner. I'm an anesthesiologist. I work currently in the Maryland area, Baltimore, DC. And I work with pregnant patients. I work with chronic pain patients. I work with patients addicted to medications such as heroin and all kinds of other things. So even in the acute setting of perioperative medicine, you're getting ready to have a surgery, I have to deal with all the things that you're talking about. But what I often see when I take care of patients that look like us is how little, or how much rather, trust they give us, you give us. I want you to put that same level of trust and diligence that you do on us on yourself, okay? So the issue of pain or health disparities overall, it's huge. There's so many components that feed into it. It's so complex. I can't fix all of these. No one person in this room that's a practitioner can fix all these things. But the one thing that I can do is I can charge you to help do your part. As a patient, when I meet you before surgery, that's the first time you're ever seeing me in your life. You meet me for maybe 5 to 15 minutes at the most, and I have my life in your hands. And you just met me. But you've been in that body for 40, 50, 60, 70 years, and you don't give yourself the same amount of responsibility that you give me. Okay? So you might not like me a lot after this talk, but I love you, and so, hey, you'll deal with it. So you have expectations. You absolutely have expectations, but where you demand them in your life shows you what your life looks like. So when you go to your favorite restaurant that you know your favorite meal, and it comes out and it's not right, you know what you expect, you tell the waiter, and they send it back and get you what you want, right? When you go get your nails done, you know what your nails should look like. When you go get your hair cut, you know what your line should look, your edge up should look like, right? Because you know what you want the outcome to be. The same thing should happen for your health care. When you go in to see your doctor, when you go in to have your appointment or your surgery or whatever, you should have some expectation and demand it, right? So how do you do that? By understanding what's going on. So doctors would be required to have 27 hours in a day, which we know is not possible. We have 24, to be able to provide all the kind of the standard guideline recommended care that you would need. We just don't have enough time to give you what you need. We don't have the time for talking to you. I know we talked about 45 minutes appointments, all the charting that we have to do. We have to call you back because you call your doctor with questions while you're home because we tell you to. So now we need to call you back while we're seeing all the patients, and we need to keep up with our families, and we need to keep up with continuing medical education. We don't have time. You have to help us out. So I want to ask a question and be honest. How many people could name all the medications that they're on right now? How many people can't? Somebody's not telling the truth. Thank you, sir. And okay, so the people who know what medications they're on, do you know what they do? Okay. This is good. Most of the time they don't. I take that little yellow pill for something. And I took it last night, and I didn't take it the other day, or I took my blood pressure medicine 3 days ago. Well, why didn't you take it yesterday? Oh, I just forgot. Well, do you know why you take that medicine, what it's supposed to do? So the things that you're putting into your body every day, put as much effort into understanding what they are as you do as the things that you put on your body, right? You research before you go to the party what you want to wear. You look it up online. You look at the cost of it. You look at the reviews of it. You go try it on at the store. But you don't know what the pill is that you put in your mouth every day. The time that you spend scrolling through Instagram and looking through text or whatever, take a couple of those moments out and look at that pill bottle and look at what that medicine does. There are YouTube videos, there are patient testimonials, there's the actual information that you get from the pharmaceutical company, but I think we waste a lot of this wonderful brain and energy and time on things that have no bearing on our lives. Use a little bit of your time to take care of yourself. I told you I was gonna be preachy. So understanding what to expect when it comes to your pain management. So when you go to the doctor, when you go to have a surgery, as Dr. Tillman talked about, they should be managing your pain like they manage your blood pressure. It is a vital sign. It has been demanded by all the major medical societies that if your blood pressure is too high, they need to bring your blood pressure down. If your pain score is inappropriate, that should be just as important to them as getting down your oxygen levels too low. Get her oxygen up. I think it was the JCO or something. They look at that when they come in to see patients. We have to document that in the operating room. Like, what was your patient's pain score when you dropped them off after surgery? What did you leave them with? I can't drop you off in the PACU in the recovery room with a pain score of 10 and just leave, because I would be dinged for that. And the hospital could potentially lose funding if we don't take care of patients' pain. So did you know that? And if you didn't, you wouldn't know that you can report that when they don't treat your pain. You can report them because they get JCO visits all the time. They get, leapfrog visits and things like that. They're looking for things like this, and your hospital could lose its certification and some of its accreditation if they don't take care of you. This right here, how many people when they were young were told that people just need to wash their neck? This is dirt. You heard that, right? You got a dirty neck. This is not filth. This is actually something called acanthosis nigricans, and what it is your body's reaction to insulin resistance, so diabetes. So little kids that walk around, because it was me, I'm still a thick woman, but when I was a kid, I was a nice chubby kid, and I remember my neck was getting a little dark, and my mom, rub your neck, clean your neck, clean your neck. She didn't know that I was on the way to becoming diabetic. So these are the kinds of things that I want us to understand about just who we are. Those dark marks that people get on their cheeks, that's the same thing. Dark marks under your armpits and your groin and things like that. This is a sign that your body isn't handling insulin well. These are small things on you that you can look up and find out more about and hopefully do something about or bring to the attention of your doctor. This little piece of information here, we get patients, because like I said, I work outside of DC. There are lots and lots of hospitals. So unlike, somewhere like North Carolina where I trained, there might be 2 or 3 major hospitals. In DC, there are 10 or 20 in a span of maybe 10 miles or something. So we can get a pregnant patient that went to 3 different doctors. The assumption that patients have that all OBGYNs and all doctors and all hospitals all talk together is a terrible assumption to make. What that means for you is that you should know your own medical history as best you can, right? So I gave out some of these little cards. If the folks who had cards, you got them. And what it's showing you is how to be prepared for your doctor's visit, but it's also just for you to be able to document your health history. Have it down. So every surgery that you've had, your allergies, what medications that you take, before you go to the doctor, what questions do you have? What things have you read about online that you want to ask about? Being prepared, because the assumption that all of us talk is a poor assumption for you to make. There's way too many medical record systems out there, and we just don't all have access to them. So a lot of times we only know what you tell us, because I can't get to your doctor because the doctor's office is closed. So you tell me what I need to know. So keep a better record of your own medical records. It's not. Oh, there you go. Last couple of slides here. So health literacy is what I'm talking about here, just understanding your health, understanding what's going on. The CDC said that if there was just a little bit better understanding of patients about what's going on with them, we would save $25 billion a year as a country. So the number one health expenditure in the country, in the United States of America, the number one thing we spend money on is national security. So our guns and our planes. The next thing that the United States of America spends money on is health care. We could save a lot of money as a country if you all just understood a little bit better about what was going on with your health. As well, $1 million or 1 million emergency room visits. It's a lot of time to sit in an emergency room that's wasted. It's a lot of frustration sitting in an emergency room. So if you understood what was going on a little bit with your health, you could maybe avoid the emergency room and go to the urgent care facility, or wait until you needed to go to the emergency room and go see your doctor right then, instead of when your foot's about to fall off. So that's what the end of my sermon there. But I charge everybody here to ask yourselves these questions. If you are going to give me this much responsibility to take care of you, I'm going to give it right back to you. Okay? Thank you.
And Dr. Johnson? Yeah, wait. We'll only have one question. Where's Dr. Johnson? All right, fine. Dr. Johnson's not here. Can we get the lights back up then? That'd be great. And all of the speakers for today, can everyone come back up to the front? We'll have a group discussion with everyone. Dr. Johnson was going to talk about. We can still get all the speakers up because I'm sure he's going to have a short discussion here. All the speakers back up front and the lights up, please. And Dr. Johnson is going to get us started by discussing resources and where do you go from here and how to find help in the Philadelphia area. We'll turn off the. All right. I can do that.
So we come to the close of this event. As we come to the close of this event, you know, it's quite obvious that this is like trying to take a small drink from a fire hydrant. This is a lot of information. This is a lot of information. And I want to thank you all for being patient and kind and participatory. And the worst thing to do is sit in front of people and they don't even acknowledge that you're there. But you've been engaging, and that has made a real difference. Again, we want to thank Zion Baptist Church for lending us this facility. You know, as I started out, you know, the bottom line for people of color, people in this community, black people, African Americans, the church remains the bedrock institution for us because it's the reliable institution. We can't trust the politicians. We can't trust the institutions. You know, you can talk all you want about strong armies, et cetera, et cetera, et cetera, but unless you have an institution that you can find refuge, you don't have anything. And so, again, we recognize that Christ is our refuge, and we find him here. And I want to thank all of our participants. This has just been a great panel. This has just been the companies that just gave freely to let us do this. And that, you know, you don't have that. You don't have that. I mean, there are people here that came on their own dime, on their own quarter, and came on their own resources, their own time. We just thank you. Just thank you. Now the question is, you know, where do I go from here, and how do I find help? Because I know you took a lot of notes and a lot of things, you took a lot of questions, et cetera, et cetera, et cetera. Do we have time to take some questions?
We're going to turn this mic off, so write down the phone number.
So, yeah. So you can call Miriam Medical Clinics to find more resources here, okay? And that phone number is 215-704-7679. 215-704-7609. Operators are standing by now. 215-704-7679. It's open for questions.
Somebody called me in the hall and asked me, you know, most of the speakers are from out of town. How do I find help in Philadelphia? Essentially, for pain doctors in general in Philly proper, there's not a lot of private practitioners because of many reasons, including the tax laws. But so essentially, pain doctors in Philly are usually at, you know, the major institutions. So Temple, Jefferson, and Penn, and that's pretty much it. But outside of Philly, there's a lot of people. So if you live, in the outskirts or want to venture to the outskirts, I think the phone number, reach out. We can recommend. Everybody here has a lot of contacts around.
And your insert in your pamphlet has the phone numbers for all of and contact information for all of the speakers today. So if you can't find somebody local, you can reach out to our clinics, and then we can try to help you get somebody that can be in your area. But now we'll open up to questions in the audience. We've got one back.
First question's over there.
Thank you. I wanted to ask a twofold question, and the first one is this. What happens when a person of our age cannot access things easily? It looks like we're advocating more and more for ourselves with the help of groups like you. So going on the internet, looking this up, finding this is just not as easy as you may think that it is, especially when you're over 70 years old. So where do we go from here? What can we do at this point to keep this line of communication ongoing, so that these people who are getting older every day can find easy access? Because some of my questions are too lengthy for now, and I'd like to have the opportunity to follow up on some of you on my own time. So if you could help us with that, that would be, I think we would all be so grateful.
Well, I said a little bit earlier, you always call your insurance company.
I'm sorry?
A little bit earlier, I said that you can always call your insurance company, ask for a case manager or a social worker, they can help you. But also, my name and number is in there. I work for the Department of Behavioral Health and Intellectual Disability Services. I sit on a committee at my job. It's called Helping Older Philadelphians. So I'm also a resource, too, to help you, to get somebody to help you. They also got senior peers, and these people that literally volunteer their time, they other seniors to help other seniors, whatever, whether it's doctor appointments, spending time with them, get them out the house, we can even take a walk. So it's resources out there. My name is Benita Tillman. I'm in the folder. Just give me a call. That's my direct cell phone number. I will help you. It's services out there.
Well, I will certainly utilize you, but as I said before, I've gone the gamut. I know all those things that you were talking about, but is there anything else that's going to be done to help older people advocate for themselves? Because doctors are just not doing it. They don't have the time.
And so,
It's programs out here. It's programs out here that they're starting to develop. That's why I want you to give me a call.
Okay.
I'm sitting on this committee at my job, but I'm also a chaplain. I work in a nursing home where they do stuff there. And so I'm all over the place. I've been giving people resources all day. I'm a committee person. I wear 99 hats. So trust me, if I do a warm handoff, you're going to get what you're asking for.
I would be glad to call you.
And I'm making a promise to you, okay? So make sure you give me a call. That's my personal cell phone number. Call me.
Thanks so much.
So in general, I mean, if you forget any of that, if you forget any phone number, the numbers are the other sites are listed there. And remember the number that I gave you that was up on the screen. What was that number? Let me give you that number again. But one of the things that we want to do as Miriam is serve as a clearinghouse, because this is a lot of information, and we want you to be able to access it relatively easily. So if you can't remember anything else, it's 215-704-7679. That's Miriam Medical Clinics. That can be your contact for if you lose those papers, if you lose everything else, call Miriam Medical Clinics, and we can put you in touch with these experts or the experts that they know in the area.
Oh, I just wanted to say that when Dr. Turner was speaking just now, I want to thank Dr. Turner for the information that you gave a few minutes ago. And you made me think about Dr. Benita when she was going through her thing with her doctor about the pain, when he wanted to give her, the treatment and everything like that. And like you were saying, Dr. Turner, hospitals can lose their funding. Like you said, they don't treat a patient right. And with JACO, because when you mentioned JACO, Dr. Turner, you made me think about my days at Cooper Hospital in Canada. I worked for 16 years. I was in charge of the Melbourne Department of Surgery. And I remember back going 20 whatever years ago, my supervisor, she would freak out. She would say, Joe, Jacob's coming soon. She said, make sure you got everything in order. And I said, who the heck is Jacob? She said, Joe, don't worry about it. Just make sure your mailroom is straight. Don't have no mail trays all over the place. I mean, she would be freaking out and stuff about that. She said, Joe, I don't even know what these people look like. You could walk right past them in the hallway and don't even know who they are. But just keep everything straight. Make sure everything is up to par because see, Jacob can get us in trouble. I said, okay, I got you, Sue. I made sure she said, be on your best behavior. So I made sure I was straight during that whole week or two that Jacob was supposed to be coming because I seen how seriously that my supervisor took Jacob. So you're actually right about Jacob, Dr. Turner. They can really, do things, so.
Yeah, so joint commission is like, daddy's getting ready to come home and everybody, runs around. But I spoke last night and I said, I always tell patients, if you're not being treated right, because I only have this quick moment to take care of you in the perioperative setting, pre-op, intra-op, post-op. When you go to the floor, I'm not there, so this is what you do. If you're not getting what you need, you ask to talk to a nursing supervisor. Nursing supervisor doesn't give you what you want, you ask to speak to patient advocates. And then if patient advocacy doesn't help you, then you go to risk management. Risk management is the lawyers of the hospital. If risk management doesn't give you what you want, then you can call your state medical board and you can report your doctor to the state medical board. And it doesn't mean they're going to lose their license. It might just start in a phone call. It might start in an investigation. I'm not trying to get people fired, but sometimes fire is the only way that people will move. And so, I don't want everything to be about being punitive, but until compassion is the reason for drive, right now the reason for drive is going to be losing your money.
Yes, thank you very much. Oh, I'm sorry. Thank you very much. I want to, first of all, say thank you to all you guys. I was just so thrilled to see all these African-American doctors in the same building at one time. I was like, oh my God, oh my God. I think I have probably talked to you guys, separately. Just to follow up on this question the lady had with the tie-dye on, we do offer classes at our Philadelphia Corporation for Aging, following up on what these doctors were, speaking about. So I've been teaching classes with them since 2015. So we teach diabetes, chronic pain, and then we teach chronic, so there is help out here. So just get in touch with Philadelphia Corporation for Aging, and they can bring classes to wherever you are. And I want to thank you guys very much. I got to go get my CCT ride now.
Good afternoon, everyone. I thank God for all of you. I thank you for opening the opportunity to supply more information to our community because there are many things that we are not told. And I realize that when you become a senior, they think you develop a block. But that's the time when your mind opens up because God gives us wisdom. And there are times when I had surgery the 8th of February, and I said to them, I do not tolerate medication. They did not listen to me, and they gave me oxycodone. And I was actually turning off the faucet in the bedroom. I had high blood pressure. I never had high blood pressure before. I was unable to use the bathroom, and I decided that I was going to pray. I got therapy, and I got acupuncture to control the pain because I could not tolerate Tylenol, etc. I couldn't tolerate anything because it felt as if my heart was coming out of my body. So I thank you for coming to our community and letting us know that there is another way to be able to survive and love and care for each other. And I thank you.
Well, as my sister over there said, I have gone to Gambit too. And I was thinking about the spinal stimulation until I do take Xarelto. So that's one thing. And I try to take all my, when I go to the doctors, I have a list. So I'll know what I'm talking about. I only can take Tylenol, and I take 650 milligrams, 2 in the morning, 1 in the afternoon, and 1 at night. But I still have pain. Now, I had a shot about 2 or 3 months ago in my hip. I had, for the first time in about 20 years, I had a full night's sleep for 2 weeks and no pain for 2 weeks. Then it went right back, because when I went back to physical therapy and he started moving my leg around for my hip, that night the pain started and haven't stopped yet. So I've been to physical therapy, I've had all the needles in my back, And someone said to me that when you get the cortisone shot or whatever with the gel, it could affect your heart. That's the question I have, because I don't know. But she did tell me that that could affect your heart. But what can you do now, as if you have gone to gambit? What do you do now?
So there's still lots of options, right? So cortisone doesn't directly affect the heart, but it can cause some temporary side effects, such as a racing heartbeat. It can cause temporary increase in your blood sugar, temporary increase in your blood pressure. When I say temporary, I mean a few days. It shouldn't be lasting for months and months. But there are options, though, even with you being on Xarelto. So the thing when I mentioned about being specific, strategic, and safe when it came to injections when patients are on blood thinners, it's not that blood thinners prevent you from being able to have access to these procedures. I do procedures, we all do procedures on patients all the time who chronically take the blood thinning medication. We just work with you and your doctor who prescribes it so that you can safely stop it for the window of time that makes it safe for us to do the procedure. So just because you happen to take a blood thinner does not mean that you may not be a candidate for one of the advanced procedures that you heard us talk about today. You just need to have communication with your pain physician and your physician who's writing your medications to make sure everybody's on the same page about what's safest for you, and it'll be effective.
Okay, well, right now, I'm like taking 20 milligrams. So as of tomorrow, I have to stop taking it for 2 days because I have to have something done on Monday.
Exactly.
And she wants to take me down to the 10 milligram because I have had a blood clot twice. But she's saying that the 10 milligram will make me bleed less, which I haven't had any problem with that, and bruise less, okay?
So and all of that is conversations that's individualized between you and your physician, and you listen to your physician who knows you and knows your history well. And it sounds like this physician is listening to you and some of your concerns, so that's great. So you keep it up, and then just make sure that line of communication is still open. But don't automatically exclude yourself from options you may have heard of today because you think you have something going on. Ask those questions, those ABCDs we talked about. Ask the questions, be open and optimistic, clarify the why, the plan, and then do your part, okay?
Okay, this is my only ailment. I don't have anything else. All I do is take Tylenol and blood thinner.
Hi, my name is Dr. Patel. When I was in medical school, first year, I lived with my grandmother, who's very diabetic, very fragile, petite lady, and she was taking all the medication that you talked about, the one dimmer switches. And one day she took those medications. She was always telling me that she feels groggy, she doesn't feel like herself. And one day she takes a pill, she's going out for a walk, she falls right down, right there, and hits her head, bleeding really profusely. And I'm trying to see what I can do for her, stop that blood, but it's bleeding profusely. I start to perform CPR because her heart gives out. I did that for 15 minutes before somebody came, and I eventually lost her right there. But even when I was in medical school, I was never told about other options other than just pills. And I want to know, like, when should patients ask for non-pill related stuff for example, diabetes, or even just for their general pain in general? And when is like those medications appropriate to ask for, and when is it not appropriate to ask for? Like, when should you start and stop those?
I'll take a stab on that one. So the very common pathophysiology or condition that I love for that analogy is diabetic neuropathy. Because a lot of these patients come in with so much on, whether it's blood thinners, insulin, medication addressing different kind of blood sugar derangement, and then pain meds in addition to that, because it's painful diabetic neuropathy. So one of the things that I always do is I go through the list of medication, and if they've actually exhausted the pain-related medications that help with the condition, the one thing I think about is, okay, have you tried topical? If they say yes, then I think about, have you tried a patch? You know, because Q10za is actually one of the things we can use, which is believe it or not, it's a spice. It's made up of capsaicin, which is it's a spice chemical that bonds to pain receptors, and that's how it actually, you know, helps with pain. But then on the other hand, so if they've failed like a capsaicin or a Q10za patch, one of the things I discuss with them is, like the stimulator, the neuromodulation, can they have some kind of electrical adjustment of the nerves that are actually going out of control? So it's a very good question, but I always go through what has worked, what hasn't worked, and then consider topical, which is not a pill form, and then consider an actual patch. And if that's not working, then I think about advanced systems.
Oh, I'll just say quickly. I think you were asking when should someone ask, and I don't think you have to wait to ask. You don't have to fail lots of medications before you look to have interventional procedures, or just physical therapy, more conservative management. So you don't have to necessarily take pills. There are other ways of treating pain. And you may need medication for your blood pressure and things like that, but diet changes may work as well. So you can always try to add in those conservative therapies. You may need the medicine for a while, but as you improve, you can always start dialing back on the medications that you take also. And if you get in with a pain management doctor sooner, you may get a lot of those interventions sooner, because some of the other doctors you're seeing may not be aware of them. So you do need to see the pain specialist.
So to put a number to it, that's what it boils down to, right? We need a number. This is really rough, doesn't apply to everyone, overgeneralization, but here are the numbers. If your pain is existing for 3 months, we call that subacute. Means that we still have some options to maybe treat the problems with your pain, okay? Post-operative, first 2 weeks, 3 weeks out of whatever injury, whatever thing you had, was subacute. We tried some medications. 6 months is definition of chronic. Right? We talked about that earlier. Chronic pelvic pain, 6 months. So across the board, when you get to 6 months and you're not progressing, you get to 6 months and you're having side effect problems with the meds that you're using for your pain, you get to 6 months and your doctors are saying, sorry, that's it, we're done, you're at the end of the line, you need to be asking for a pain doctor. All right? So anything over 6 months for chronic pain, you should be seeing a pain doctor.
Because when we talk about pain doctors, we are all pain physicians, well, most of us are pain physicians. However, there's a difference between a doctor who just prescribes pain medication and a doctor who does what we do. So we are board-certified interventional pain physicians. We are anesthesiologists, PM&R physicians, neurologists, psychiatrists, whoever, who've done additional training in pain management and are board-certified. So I'd encourage you not to just ask for a pain doctor, but for a board-certified pain doctor. And that is a separate definition that gives you access to the types of treatments we've been discussing.
I just wanted to jump off of that a little bit and empower you to ask that question too. I can't tell you how many of my patients who don't look like me ask me what kind of training I had to do what I do. And a lot of the patients who look like me come in and they blindly trust me, which I think I'm pretty trustworthy. But I think it is okay to ask people, where did you learn this? Are you board certified? What are you going to do that's different from the other doctors that I've seen? And I would say if there's anything that, we discussed a lot today, but feeling empowered to ask those questions. And also, I think of the doctor-patient relationship just like any relationship. I love my wife. We've been married for a long time, but before we started dating, I dated a few other people, and those relationships needed to end. And so there may be physicians who you currently see where that relationship needs to end because it's not functional.
And let me just follow up on that by stating that I live in a town outside of San Francisco, and I went around town and looked at all the signs that said pain management, pain doctor here. I'm the only one in town that offers the therapies we talked about today. There's over 100 in my little small town that can be anything from lasers to crystals to magnetism. All sorts of people put the label pain clinic here, pain doctor here. Definitely ask for board certified by the American College of Medical Specialists for board certification in pain management treatments.
So I just wanted to say that the pain doesn't just come in older adults, younger adults too. I'm only 52, and I had was diagnosed with scoliosis when I was in elementary school, and I was diagnosed with rheumatoid arthritis when I was in my late 30s, early 40s. What else? Tendinitis the past few years, and like my mom, we both had back issues, and my sons tell me, well, Mom, you're only like in your 50s, you're too old to be having all these issues, and you need to work on that so you can be like Nana and travel and all that. And like I try to go to different, I know like certain people sometimes saying something about the diet, and sometimes I do try to cut out the glucose and stuff, and I do see a little difference with that. And I try to do yoga and different things. But far as my doctor did mention chiropractors, but I saw on TV that kind of scared me where some people had that and they're wound up in wheelchairs, so I never tried it because I was too scared to do that. And I don't know, like, since I had it since I was in elementary school, I don't know if that would be a good idea to do that or not. And I don't know if that's the reason why I'm having more back issues, because I had that since I was younger. So, any thoughts on that?
So I'm glad you brought that up, because the other thing is that pain doesn't discriminate. I was talking to somebody today who talked about children with sickle cell and who have sickle cell crisis in the hospital, and they're 2 and 3 and 1 years old in excruciating pain. So age is not a requirement to have chronic pain or pain that affects your function. What we've talked about today can apply to almost any age group, and what the common theme is to advocate for yourself so that you can get access to the treatments that can potentially help your pain. The first critical thing is figuring out exactly what's causing the pain, and then once you figure that out, we have treatment options that can apply. But just because you're not too young to have, you could have been in a car accident and had something happen to your leg and be 17 years old. I know we've all personally treated, teenagers all the way up with chronic pain because of something that's happened. So the fact is that pain is robbing you from doing something you want to do, travel, be with your kids, and there are treatments for it. And go out there and find a physician that is going to listen to you, going to take the time to diagnose you, and give you the treatment options that you deserve.
Sorry to interrupt really quickly. Please, I know people are stepping out and starting to leave, which is fair, but there is a post-symposium survey in your folder. If you could please fill it out, you can leave it at the front when you're leaving. Sorry, next question.
Just a quick comment about advocacy. I like to think that advocacy is a family affair. So if you have young health professionals in your family, let them know they're needed to participate in your conversations, because that's been such a blessing in our family.
Okay, what do you doctors think about the effectiveness of CBD oil from the hemp marijuana plant? What do you think about that?
Marijuana, CBD,
in pain relief?
So medical marijuana is an alternative treatment. The research on it, there are some studies, but there are no multi-center studies. The actual, the actual mechanism of action, although we know some of it, is not completely, deciphered yet. However, the practicality of it, I personally, when I was here at Temple, I recommended medical marijuana, and now in Delaware I do the same. And I have a lot of patients that actually was able to get off of opioids and do well. So the caveat to that is since it's still a federally illegal quote unquote drug, that our role in it is purely just to recommend it, and then you personally go to the shop or to the dispensary, and then you talk to a non-doctor who gives you different kind of potential, formulations, and then you kind of figure out what works for you. And so it's a little bit of a discombobulated process, but in practicality, there are people who do very well with it.
Yeah, I wanted to also take a stab at that, because you spoke specifically about CBD, and there are two chemicals that are in marijuana that are broken out. So there's THC and there's CBD. So THC is kind of thought of as the part of the marijuana plant that gets you high. And CBD is another part of the marijuana plant that has been proposed to have some anti-inflammatory properties. I think what was said is right on point in that we're a little our hands are tied because marijuana is federally illegal. It's been passed by the states, but most of the money that physicians use to do research on drugs is given by the federal government. So the federal government says something's illegal, we can't really research it. So we can't really look into the effects the same way we can with other drugs, and we can't look into the doses like we can with other drugs, right? So since we can't prescribe it, we can't say take X amount so many times a day. I will say, though, that when you look at some of the drugs that we currently prescribe, a lot of them also came from plants. So aspirin, for example, a few others came directly from plant derivatives. So, or opioids from poppy plants. So I don't think we can necessarily say just because we haven't had experience with it that it doesn't work, because it does work for some people. One of the challenges with CBD is because it's not very well regulated, you could buy CBD at a lot of different places and be getting 1,000 milligrams one place and 5 milligrams another place, and then we can't really give advice on whether it can help you. And so kind of the preliminary studies that have been done in other countries show that CBD does potentially have some anti-inflammatory effects. I don't think it works very well for neuropathic pain. THC seems to work better for neuropathic pain, but again, we don't really know the answer.
Yes, I had a two-part question.
One quick last part about the THC. As a perioperative doctor or anesthesiologist, because marijuana is federally illegal, lots of patients don't tell us how much they use, how often they use it, how much they use it. Marijuana increases your anesthetic requirement. It increases how much anesthesia you need. So if you are using these drugs, if you're smoking marijuana, if you're taking gummies, if you're doing whatever, please I'm not going to report you. I don't have anything to gain by telling the FDA or DEA or whatever that you're using these drugs. But for anesthesia, sedation procedures, if you're using any of these drugs, please be honest about how much it is that you're taking, because you could be laying on that table and not getting enough anesthesia, and we've already heard what that story sounds like.
Okay. If you had ongoing pain for a while, but it's not chronic or excruciating, how come wanting an MRI, the doctor always wants that to be the last resort for you to find out exactly what that pain is? They always want you to try therapy, try medicine. They hold out really long with letting you get that MRI to see exactly why the pain is there. And then my second question is there any natural herbs or anything that somebody whose pain isn't chronic could take, such as turmeric? I hear that being used a lot as something that you can take when you have joint pain. Are there any other natural suggestions that you have for someone that's not suffering with ongoing excruciating pain?
Yep. With regard to the MRIs, most of the time, it's not your doctor who's necessarily putting up the resistance, it's the insurance company's rules that we got to play by. And oftentimes, if it's a back pain issue, then you have to have x-rays first, 4 to 6 weeks, or 4 to 8 weeks of physical therapy, and some kind of neurologic deficit or some kind of physical sign on exam to get that MRI authorized. So and a lot of the time, it's $1,000 out of pocket, and they're pretty expensive. So that's I think the source of a lot of that resistance to go straight to them.
Yes. Thank you very much.
Hold on, but there's a second part to the question.
Yeah, I wanted to make sure we answered the second part of the question. A lot of that is similar to the marijuana question, where we don't have the level of research. There's a certain amount of research that takes to get to a drug to market. And so if something comes to market as a vitamin or a mineral or an herbal, then it doesn't have the same level of research. Now, that being said, like I said, I live in Arkansas, and I've been called hippy-dippy. I believe in kind of changing diets. I work with an acupuncturist. I talk about some herbal things in my practice. And so I do have patients who take turmeric and say that it helps. You know, like we said, I think someone said earlier, anything that is cost effective and doesn't have much side effects, I think it's worth trying. I would say also for arthritis, there are a lot of patients who take glucosamine, and sometimes that can be helpful, and some of you have probably heard of that. So I think the thing we have to be careful of is a lot of those herbals can often have side effects the same ways that medications have. So for example, like garlic can make you bleed more, for example. And so also really, and you don't necessarily have a doctor guiding you to help you with those side effects. So that's kind of the caution, is that, and also the dosing, similar to the marijuana question, you could buy it from Walgreens and get one dose and buy it from CVS and get another dose. And so really making sure that you do your research and also talk to your doctor about those things that you're thinking about taking so that they can provide advice if they know a little bit about them.
Thank you. I get up every morning. I really love what I do, working in the health field. And I just get up and do what I do because I love it. And I just want to say, everyone standing there, I know you guys probably do the same thing. You get up, do what you love to do. But all of you standing there has made a major difference, I'm sure, in everyone sitting here that was here or is even going to hear about what happened today. And I'm sure it will vibrate because you guys were wonderful. And I want to thank you for that. And the other thing I want to say is, other than a TV show, there is nowhere that I can think of, and I challenge anybody else, to see so many doctors in one room paying attention to the public. Thank you so very much.
Hello. I have a question about pain, but it's a different type of pain. My daughter has been having pain in her eyes for quite a few years. She's gone to quite a few eye doctors. And I was just wondering, do you think maybe she should go to a medical pain doctor to see if they could maybe help her with her eye
In
condition?
both eyes at the same time, or in the back of her eye? Does it come and go?
It's both eyes as far as I can think right now. And it does come and go. Sometimes it seems to be steady, but it comes and goes.
There's a type of headaches that could called cluster headaches that could be that. She would have to see a doctor to make sure that she fits those criteria, and it's actually a pretty straightforward treatment for that, but I'm not sure if that's the headache she has, but she should see somebody, like, did she have an eye doctor?
She's been to a lot of eye doctors. She's been to a doctor that has given her prisms for her glasses and all kinds of things.
And nobody could find out.
But no, it's nothing that really solves the problem for long term.
Well,
And she's had
it certainly sounds like there's at least one pain doctor in your region who would like to see her.
Yeah, I'm happy to see
So
that.
now you know there is a pain doctor who's willing to talk to you about that and evaluate that.
Thank you.
There's a new medication out. It's supposed to be for menopause. Is anybody familiar with that? It came on the TV real quick. All I know is begin with a V, and I didn't catch it at all. I've been looking for the commercial. And how does anybody feel about those combo patches? It's supposed to be for menopause. Combo patches, nobody? Oh, for somebody else.
If it's
Oh,
for
okay. I
menopause,
thought that
if you
might
talk to your
have something
GYN,
to
they
do.
would know about it.
We had one here
Okay.
earlier,
Would
but
that
he
relate
stepped out.
anything
but
to pain? Okay. All right.
Sorry.
Okay, maybe it's not.
This is why pain doctors.
No, I thought I heard the one with the orange. I thought you were speaking about another, because my neurologist is saying that that's coming from my nerves, and I don't understand that. She said I'm out of menopause, and the pain that I'm getting is coming from my nerves. So I don't understand
Well,
that.
if
So I
it's
don't know
your-
how to
if
actually
it's-
ask the question.
If it's your neurologist that's saying that it's pain coming from your nerves, then seeking out a pain physician who's specialized and trained in evaluating those causes of pain will probably be the next step. Because if the neurologist is telling you it's coming from your nurse, but they're not giving you a treatment targeting whatever they think it's coming from. It may be that they're not comfortable or familiar with options that may be available, but like we heard today when we were talking about chronic pelvic pain or chronic other types of pain, there are doctors who specialize and who know about these different treatments and may be able to offer you something. Doesn't have to be what we just saw on television. It could be something very simple. It just depends on figuring out exactly what's causing the pain.
Thank you so much.
When I was first dating my wife 40-some years ago, and her grandmother found out that I was in medical school, and she brought this box that had like, I don't know, 20 bottles in it, and just all different labels and different dates. And she says, if you're so smart, what are these? And today, whenever they say on television, ask your doctor, I think about that. I have no idea. So I'm saying that to say, that particular question you want to address to that particular type of physician or profession. Then get a new one. And so if that doctor can't answer that question, find someone who can. Because the explosion of medications, you know, like you used to have aspirin and Tylenol. Now there's, I don't know, there's a new drug every 5 minutes, every day there's a new drug. When they say ask your doctor really may not know. He may have just been learning it on the commercial himself. Ask your pharmacist. Ask your pharmacist. And the pharmacist is really the last line of defense between you and your doctor. So ask your pharmacist.
I'd like to also mention that as pain physicians, all of us up here, we treat pain from the top of the head to the bottom of the feet and everything in between. And as a result, we cover every other medical specialty. Chest pain, I get from cardiologists. Lung pain, I get from the pulmonologist. Head pain, I get from the neurologists and the neurosurgeons. Bladder pain from the urologists. Pelvic pain from the OBGYNs. Knee pain and back pain from the orthopedic and spine surgeons. Foot pain from the podiatrists. So everywhere along the way, we need to collaborate with them. They'll tell us the latest that they're doing, and we work with them. So your pain doctors and your other, what I call fix-it doctors, need to be working together. And the most important thing is to get your doctors to engage in that, because when they don't, it makes it less beneficial care for yourself. But I'm on the phone with doctors of every specialty every week about one of my patients or another. So that's how we try to collaborate to make sure there's a new pain patch. I see a lot of folks with endometriosis who are getting a lot of hormonal therapy, but I work very, very closely with my GYN physicians who are prescribing various hormonal therapies, and they're working with me to see how I can help manage the nerve pains a little bit better. So it's a collaboration. It's not like one doctor does one thing. It is a community.
Hi, everyone. I first like to thank all of you for being here and send out a special thank you for my nephew, Yusef. Yes, I just adopted him, okay. I do suffer from chronic pain. As I was speaking to him and I was telling him, I don't know if I told him this part, but I have a doctor for every part of my body. And when you guys said, if you don't like the answer you get from one doctor, go to another doctor, I have records in almost every hospital in Philadelphia. So I still and I will continue to search and keep searching until I'm satisfied with whatever treatment I'm getting. Just to throw some of what I'm going through, I do suffer from chronic pain head to toe. I've had double knee replacement. I have atrial fibrillation. I have interstitial lungs disease and arthritis running throughout all of my body. Doctors are waiting to do hand surgery, left hip surgery, a whole bunch of other stuff too. So I just say that I am a walking miracle, because if I didn't tell y'all that, y'all wouldn't know none of that. So I thank God, though, for prayer. I thank my Lord and Savior for healing. In 2017, I literally went through drug withdrawal because of medications. Medications that the doctors put me on. I just turned 70, and all the medications that I was on, I didn't even know that most of them were addictive. So I thought to myself one day, why am I in all this pain and I'm on all this medicine? So I go to get my pain medication refilled. By this time, the doctors are nervous because they got a lot of us seniors addicted. I go to see my neurologist. They won't see me. They won't talk to me. They won't answer my calls. And yes, they were from Temple Hospital. I walked to Temple. I live 3 blocks away. I walked through Temple and went up to the department, and the woman at the desk was so annoyed with me because I said, I need to speak to my doctor, and I need to speak to her now. Bring her out. They said, she's not here. I said, okay, well, let me speak to somebody else. She said, well, you don't have an appointment. I said, no, but I need my medications, and no one is filling it for me. And she said, well, I can't do anything. You had to see your doctor. So another doctor walked from behind there. I said, excuse me, are you a neurologist? He said, yeah. I said, I need my medication. Could you write it for me? He said, no, I'm not your doctor. I said, yeah, but you're here and you work at this neurology department. All you got to do is pull my file. Why can't you pull my file and rewrite my prescriptions? He said he couldn't do it, and I was so frustrated. I walked back home. That was on November the 1st was when I ran out. By November the 10th, I'm feeling withdrawal symptoms. By that time, after I walked to the hospital and I got nothing done and accomplished, I literally knew that I was going through withdrawal. By Thanksgiving, I was in it, dead in it, and I went through it by myself. And I talked to my Lord and Savior, and I said, God, I know that I am in withdrawal. I said, but if you get me through this, I will never let another doctor do this to me ever again. Sure enough, I go through withdrawal with having atrial fibrillation. I felt like my heart was going to explode. So I said to my family, I'm not coming to Thanksgiving. I said, I'm going through drug withdrawal. I said, but I promise you, I won't die here. If it gets that bad, I will make sure I go to the hospital. I went to see my cardiologist at one of my many hospitals. I caught Lyft, and I went to see I went to the emergency room where my cardiologists were. I have 2, one for the electrical component and the regular heart. I go to the emergency room, and the guy says, yes, you are in withdrawal, but you're not dying. I was like, okay, I just want to make sure. And he gave me IV. I went home, and I finished my withdrawal. Didn't get out of it until just before Christmas, the 20th. Wow. All that time. When I tell you I understand why people can't get off drugs, that was the hardest things, and I thought labor was hard, but that was one of the hardest things I've ever went through. It was just the most sickening thing that you can go through with the headaches, the nausea, so extremely weak. I couldn't even make it to my own restroom, let me just say that. So, but I thank God I got off of the medications, and now I have slowly added them in, but I mostly live off of Tylenol now. Well, and I suffer with chronic pain. When I tell you some days I can't move, I got a heating pad and a cat and a comfortable chair, and that's what I do.
Well, you are so strong, and you have made it through, and that is really tough. That's one of the things we were talking about opioid dependence. So even though you don't realize, you don't think it, your brain, you're not craving it, you're not going out on the streets looking for it, your body is still dependent on the medication. However, we have come to the end of today's session. I'd like to thank all of you so much for your attention, for your participation. I'd like to thank my co-panelists for your insightful conversations and presentations, for dedicating your time and effort to this event. Please make sure you go out and do your part, advocate for yourself. You have, if you need packets or if you want to give packets to anybody who didn't make it, we have some more brochures up here. And then the post-questionnaire is in your folder. Please make sure you fill it out before you leave and hand it up front to check out. We want to be able to make sure that this has been impactful for you. Spread the word, and we'll keep you posted when we have another event. Thank you so much for coming out.